Hi, good morning. This is our last session of Rise and Fall of Medicine that myself and Dr. Joel Prevalent did at the Osher USF Poly class in March of 2023. In the first two sessions, we talked about the progress of medicine, which included from the dawn of penicillin to insulin to genetics, and then the organ transplant and the heydays of discoveries in diagnostic technologies such as CT scan, MRI, and then some of the failures as the so-called war on cancer that did not work out so well during the Nixon era, and to the rise of genomic medicine, and to the brave new world of molecular biology and intentionally designed drugs, to the current area of stem cells transplant and in vitro fertilization. So we talked about some of these successes. At the same time, we have seen the continued concerns with the rising cost of medicine from 1960 onwards. And we talked about the inequality and other problems that we have encountered. So in this issue, we'll focus more on the failures of medicine as to how, in spite of our spending almost nearly 20% of the US gross domestic product, there is still people are not satisfied and our data is not very good overall compared to other developing countries. So let's dwell into it. Okay, and this is the US healthcare, which we talked about as to how the decline of the trust. There are some glimmers of hope, such as most recently the insulin cost has been controlled. And here we talked about how the US is outliers, since we are not getting bang for our buck, so to speak. And our criteria for healthcare are very still far dismal, not horrible, but poor, including infant mortality, low birth babies. Then we talked about this is not just the United States, but all the developing countries are having problems. Perhaps the root cause of that may be that we are not living longer, and with aging, the disease is marching on. And so the biggest culprit is still age-related diseases that we have. And we had two forms. We thought everything answered lied in genetics, but that hasn't panned out to be as well as we thought. Or it turns out that perhaps it's a lot more complicated than we realized. And then we bring the so-called society-related or epidemiology-related diseases as to we relied on data. But again, we see the outliers, and the human behavior has been hard to modify. And we are experiencing the disease of affluence that with focus on low-fat diet, people just simply increase their carbohydrates. And so the obesity epidemic is we are all very well aware of. And this is some of the physicians who have been involved or in the forefronts of American healthcare have written some varieties of soul-searching studies, and this is one of the works that I relied on quite a bit as to how we seem to be doing things backward. As to we have tried all the other most expensive routes with and selected treatment. In fact, for example, the other countries will settle for a simple stool for awkward blood test to screen for cancer, while we end up doing $10,000 worth of colonoscopy. Okay, and the same time, sometimes the cesarean section of some obstetricians is far higher because they just want to get home and have a nice weekend. And at the same time, some of the cosmetic surgeries, are getting more expensive, and we're administering chemotherapy, even though we know that the outcome, because there's something about the American psyche that we want to treat people and do everything we can. And obviously, that's not just American physicians. All the other physicians have this route. The passive inactivity has been frowned upon now, and at least we tried. That's the mantra that we're all taught in medical school, that even we will do cardiopulmonary resuscitation, even on a 90-year-old, where we know that it's a losing endeavor. Okay, and you can just see that these are some of the data that we said, that it's just, okay, that the healthcare cost is, just the graph is on upward and upward. And by 2040, we'll be spending, as much as, makes you shudder, 35% of our gross domestic product, So the projections are dismal, to say, unless we do something about it. At the same time, the inequality we had talked about that's still, amongst various minorities is still substantial. And there's a lot of discontent that we'll talk about. And the bills, and the surprising bills, everybody knows about it. Even within Florida, the bills can vary dramatically. And all people are guilty, all the actors involved in the healthcare delivery system, starting from hospitals, where they, in the name of charity, they have a tax-free status while they may provide only a relatively small amount of charity. And they are big establishments. You can see their revenues are nothing to sneeze at, how many millions and hours, even though the hospital stay has come down. And the CEOs are handsomely rewarded, and there is massive enterprises, and they have learned to game the system with the disease-related grouping that was instituted back in the mid-'80s. And in spite of Medicare's best effort, the costs have not come down. The hospitals and the insurance industry have learned to game the system, as I call it. And again, the training for new graduates is getting longer and longer. It's been just 7 years for some subspecialties, and no surprise that they would want to make more than $500,000. They want to catch up in a hurry for all the debts that they've accumulated. Things. So, and sometimes the hospitals can be tougher than your local bookie. They would garnish your wages, and some of the stories that we hear as to how even the people who are earning $15, their salaries are garnished by the hospitals. Okay, and physicians are not without their blame. In fact, they're playing a very strong role. That there are a lot of impaired physicians who continue to practice. They're all interested in increasing the revenue, and the specialty societies have their lobbying shares. And then there are assistants who are not part of the network, and they charge in 5-digit numbers for assisting surgery, even though you may not see it. The anesthesia have even a better gaming system that they would charge for supervising a nurse anesthetist. And when the doctors own the equipment or the facility where this care is delivered, then they're making out like a bandit type of thing. And they're specializing more and more in terms of, like, for example, like doing fistula rather than doing actual dialysis. And obviously the underpaid specialties have a tougher time, such as psychiatry and neurology. And again, so the doctors and patients both seem to be playing a game of a sort. And doctors have got complex, not just surgeons, but a lot of doctors. And the patients also have, tried to get as many facilities, even though they know darn well they don't need antibiotics. But again, the act of doing something, type things. And people do not want to walk with a cane. Okay, they would rather have a $70,000 hip replacement. Because in America, you rarely see anybody walking with a cane, a walking stick. Okay, so it's just considered a no-no. I mean, that's for old people. I mean, an 80-year-old would frown upon if you suggest that, yes, walking with a cane would reduce the pain that they experience when they get home from the shopping trip. Okay, so this is, so, and again, there were outliers we talked about, type of thing as to we are taking, and the back surgery, United States does more back surgeries than a lot of other developed countries. Okay, and again, so that there's, okay, and the chemotherapy, even on terminal patients, is being done. People stage out procedures. One time they do endoscopy, bring the patient back in for a few days later for polyp removal. And again, the dermatologists have been a bigger game that they do with skin surgery. And the USMDs are obviously some of the highest paid. Obviously not as high as the CEOs, but they're being paid very handsomely for their training and their effort. Okay, and again, they always have to claim that there is a malpractice is a big problem, but it only happens in only a couple of specialties, not all of them by any means. Okay, getting down to the third big actor, i.e. Big Pharma, the advertisement that rules that change in the mid-'80s, and there you're paying for it, And then again, there are the coupons and the discounts and the advertisement for even they end up buying the generic companies. So even the generics are cheaper. And the drug, which has been around for ages, such as nitroglycerin, digitalis, epinephrine, they're all expensive. The simple inhaler has gone through the roof for asthma. And with and asthma due to pollution and living in the cities has exploded, especially in the poorer communities. And again, that some of the treatment which have to be questioned, have more side effects than you realize, such as Prozac. Okay. Okay, this is nothing, I would we'll talk about it later. And there are other things, such as the joint replacement, valve replacement, that they are approved, by FDA because the devices are similar. So we talked about it. And the pathologists, they're charged for biopsies. If they're not part of a network, then it is higher. And there are actually protocols that will tell you what type of tests you should order without even thinking at all about it. So you just have a cookbook approach. Physical therapy, just from getting you out of bed, would cost you $150. So, and the newer devices, they are not always necessarily better. So we end up paying a lot more for complication for the devices which may have not all the bugs worked out. Okay, and there are other services, joints have no warranty. We already talked about that, and the things. So, okay, so that's what we had talked about on the day 3. So now we'll dwell into day 4. Here we'll talk about varieties of problems, And let's just go over the headlines which appeared within the last couple of days. That people are, with the cost being so high, that people are forced to go for medical tourism is a big business across the border. And Mexico being south of the border, this is where unfortunately these poor people were. Some of them were kidnapped because they were in the wrong place at the wrong time. And it just across the border, there's all sorts of facilities being offered, not just for buying medications, but for having surgery type thing. And even people are going as far as India for medical tourism. At the same time, the headline in the recent Time magazine that is long waits, short appointments, hospital, huge bills. U.S. healthcare is causing a burnout to the patients and to the physicians. As many as 43% of people are unsatisfied with their medical system, and compared to only 22% in the United Kingdom and 26% in Canada. And again, after the pandemic, these numbers have even gotten worse type of thing. So this was the data from public affairs research. So I hope, and one can safely assume it's unbiased. And then medical debt, this was the headlines just from a couple of days ago on NPR, as to affects millions. And there is, 1 in 4 people are in debt due to medical costs. And so this is very much in the news, and it is reached into a breaking point. That's the point I wanted to get across. Not to be outdone, we are all seeking cure for give me the new drug to heal my ills. So in obesity, that is the big epidemic, is being now tackled with injectable therapy, which are called, we've all heard about ChatGPT, which was the artificial intelligence. But the GLP-1 is also in the news. The GLP-1 inhibitors. These are the type of drugs which would have you produce more insulin and from your pancreas and excrete the sugar in your urine. So these are the new go-to drug for weight reduction. And the 2 drugs are available. One is for type 2 diabetes. The second is purely marketed for weight loss, and the indication has been approved. And it says a very unworthy name, so I shan't even try to pronounce it. But that's the big thing. And the cost of this drug is, wait for it, it can be anywhere from $900 to $1,300 per month. And even then, the people who are more affluent are jumping the gun, so that the people who really need it have to wait in line, and they're not the companies. And the economists, obviously, they're interested in how people can make money. They say the current issues stated that the market for these drugs is going to be bigger than all the cancer drugs combined. Is in the neighborhood of $150 billion. The companies that are making this. Okay, so that's another thing. So, and this is, let's see if I can open this. This is a PDF that I have not generally tried to open a PDF in this thing, but see if I can make it work. Okay, it opened on this side, so let me stop the first share, and I will start a second share screen. Okay, let's see if this is, yeah, hopefully it will work. If you can see my slide, okay, so we'll go through this PDF, so this is the first time I'm trying it. So the healthcare report in America. So, and I will send this out to do, but I just thought it was worthwhile reading. So it's a 38-page report, so I'm certainly not going to read it. 44%, I've already alluded to some of the percentage. And so these numbers are, and the grades that we are receiving on sites, I have this as a slide form also. You can see that the overall, we're getting a C minus. So if we had a coach, he would get fired. The cost of care, we're getting a D minus from a large variety of a population. Quality of care, access to care, C. So we're not doing so hard overall. That's the point, is when we want to make. Affordability, people are not able to afford it, and there's no safety net as to how it is going to be when we get older. That remains to be seen. Okay, again, so this is divided along the lines as to our most negative about the cost of the care. Women and Hispanics are more negative, as well as Asian Americans. So that is, so it depends upon how good your coverage is. So the numbers are decimal. That's the point I'd want to make, basically. So this is broken down into various subcategories, okay, type thing. So let's just, you can look at it at your convenience if you're interested, but this is, and again, nearly 1 out of 5 African-American patients had to cut back on the healthcare. And it gives sub-analysis of the cost is desperate, insecure, and 60% secure. So, okay, I'll stop this share particularly, and we'll start a new share screen. Okay, let's see if we can get this to work out. Yes, share screen. Okay, hopefully you should be able to see my slide. Let me get rid of this PDF. Okay, that worked, so that was very nice to see that thing. And we talked about the medical tourism business. Okay, all right. And so this is again, but I'm rehashing the point because it's a very important point, so this is that major problems that we have sometimes include okay, so hopefully you're able to see my screen, type of thing. And okay. I'm not sure whether you're seeing the screen or not, so let me just minimize and be absolutely sure that you're seeing the screen. Okay, I'm going to minimize some of these other windows, stop share, and share again. Yeah, I think it should be working now because I see the green light that flashed on me. Okay, all right, let's see what I have, my notes here. Okay, yeah, we are in business, and hopefully you're able to see my slides, and so the preventable medical errors, and then poor mortality rates, and then the biggest problem with the hospital is lack of transparency. When you go in the emergency room, you have no idea how much it's going to cost. There's no apparent honesty, and then there were nickel and dime you to death. So, for example, a simple intravenous that may cost them $5 or $2 would be end up paying $100, and the cost of even a simple three sutures can be in the range of four-digit numbers, and so the cost is just have gone through the roof, to put it mildly. And then again, physicians and nurses are getting burnt out, so there is a huge amount of inefficiency in the system. I would say the root cause of that. So these are again outlined: the staff, the drugs, complications, technology. So we are treating disease after the fact, so to speak, not before it happens. So that is our biggest problem. And why all this? Simply, we're all living longer. It's the biggest problem is aging. Okay, this is what I showed this slide during my aging class earlier, and these are some of the challenges that occur. So from childhood, no wonder we called it old age is second childhood. because by the time, we can see if we all live long enough, all men at least, we'll have prostate problems. Arthritis, is your friendly companion. And my brother-in-law works at a VA clinic, and he's inundated by requests for the prescription for Viagra. Okay, so this is, and so the obesity and aging are the biggest diseases, and some people who are doing research on aging want to blame aging as a disease, and really doing all sorts of manners to reverse the natural clock. Whether it would work or not, that remains to be seen. Again, as at the same time, we are the most successful species. You can just see how we have succeeded remarkably from 1950s onwards, or 1900 onwards, in terms of reducing our mortality and morbidity. So we have been remarkably successful, in preventing infectious diseases and even some of the chronic diseases. We seem to be making a strong headway. And no wonder the population of the world is expanding and the need is increasing. Okay, and it's the data even for so-called third world countries, which is not considered a politically correct expression nowadays, but that's even in India, we can see the life expectancy is in the 70s and 80s, and people are getting all the disease of old age and chronic diseases. Okay, all right, so moving along. These are some of the references that I've used liberally for collecting this material. I've talked about Elizabeth Rosenthal's book, Marty McCarry, who's a pancreatic cancer surgeon. And yes, he does the entire pancreas, not just the head of the pancreas, by the way. So that specialization has not, but he's mostly devoted to healthcare policy. So he's written varieties of books. Eric Topol is a cardiologist who's into precision medicine and genomic medicine. So he has written varieties of books. Emmanuel Ezekiel, who's a health policy expert, was the Obama administration in his brother. So he has written varieties of books. Okay, and then another Canadian internist that is a gastroenterologist from Ireland who has written the same problem, explaining to the other side of the Atlantic. Okay, and again, this is another data sheet, which explains as to how, the crisis is critical in U.S. health, not just, okay, and this side we can focus. So we're dealing with this fraud, outright fraud. People on Medicare are billing millions of dollars, some outlier physicians. Same thing happened, we saw during the drug epidemic. And secondly, prevention failures. We are not able to make dent at abuse, such as drug substance abuse, alcohol abuse, and obviously diet. So that prevention failure, we do not have mental health counseling, and we are treating more and more gunshot wounds, stands to reason. Similarly, we don't have any social this thing. So children who are treated in newborn intensive unit, they cannot the parents cannot afford basic nutrition or don't pay attention to vaccination and prevention. Okay, and the prices are inflated, as we talked about, the simple suture can end up costing $5,000, $10,000. And the delivery system is, most of the people who do not have access to primary care end up going to the emergency room for dry eyes or for ingrowing toenail. And the administrative cost, the buildings are becoming palatial, and then unnecessary surgery. Okay, this is this is my way. I like to do the best way type of thing. So physicians have their own excuses, and obviously there's a self-interest. Okay, and so, and again, a small percentage of patients towards the end of life, end up costing a lot more. And compared to a national health system, we're spending more than 5 times the total. Okay, and these are some of the numbers that we talked about. They're just mind-boggling. America's spending grew 8.5% in 2021 to $900 billion, or 21% of the total national health. So it's the numbers are just mind-boggling. That's all one can say, type of thing. So, and private health source spending grew to 5.8%. Okay, and and 100 million people have healthcare debts according to recent investigation. Okay. All right, and then again, now let's talk a little bit more about the pharma type of thing as to how the payment system is a tremendously complicated type of thing. So, for example, here's a poor patient who needs medication. Plan sponsor, pays $185. Patient pays $35, and then goes to the pharmacy, who earns a very small amount. Wholesaler earns even less amount, and the drug manufacturer, had listed the drug for $300 and ends up getting $137. Guess who is making out in between? There's a whole category of people who are called the pharmacy benefit manager. They help negotiate prices. So they're like the bookies, between the drug manufacturers, the wholesaler, and the pharmacies. Okay, and so they're making out like a bandit. You can just see that some of these well-known drugs. Okay, let me just go off the Zoom. Okay, let's do. Okay, sorry, my slide slipped. Okay, here we go. Okay, these are. You can just see that the revenue and profit, the manufacturers gross profit is this much. Okay, while the wholesaler, earns $3, so it's very relatively small. In a pharmacy, their profit is not this thing, but the pharmacy business managers are the ones who are making out quite a bit. Okay, and we know the cost of even the common drugs such as EpiPen. The list price. The Wall Street Journal had done an article in 2017. This is my source material for this. That the EpiPen list price was $608. Okay, and it was almost $150 a few years ago. So the prices have been jacked up dramatically. And then again, the list price, another list price you can find is $300, where you don't get rebates. There are comparative equivalent drug which costs $110. But at the same time, another company has a slightly modified product, and there the sticker shock is $4,500 for the same drug or a similar drug. But okay, so it's just unreal as to how they. Okay, and it is a very complicated price flow. See if you can even follow that by any means, as to how the arrows suggest us to from pharmacy to the patient. There are a lot of layers in between. The reimbursement that goes through pharmacy benefit manager, third-party payer plan, manufacturer. So you can see how different actors are involved in this complicated chain that is the price flow. Okay, and the next slide makes it even more clear that some of the common drugs where we see as to the amount paid to the pharmacy, well, you can say, well, how come the pharmacy doesn't need any? Because they do make some money, which comes from your copay. Okay, and here you can just see the spread, which is the amount, which is called, just like the bookies have the spread. This is the difference when the pharmacy business manager charges the employer what they paid out to the pharmacy. So, the amount paid out by the insurance companies is this much, and the spread what the business manager and the pharmacy business manager get, type of thing. That's nothing to sneeze at. They're making out like a bandit on some of these drugs, such as Lexapro, antibiotic. You can see that the profits are, and the pharmacy benefit managers, and see how they are making out a lot larger portion ends up going to them rather than to the pharmacy and your insurance company. You may not pay it, but your insurance company pays it, and it's reflected in your next year's insurance premium. Okay, so it's not free. It's just a misnomer when we say it's relatively free. Okay, and there are varieties of solutions that can be, which has pretty very on a global level and working on the monopolies type thing and encouraging nonprofit manufacturing. Okay, and the lobbying is a big factor, which we'll mostly talk about. What can we do in the United States? Again, we threw away the biggest benefit that we had, which was being able to negotiate the prices with the pharmaceuticals. That was the lobbying super successful. And the physicians level, we need to be aware of how much it costs and the lack of advocacy. Big play part. We're not acting in the best interest of the patient. It's a sad but harsh truth. Okay, there is a silver lining nowadays that the current administration is trying to make some changes. They are slowly but steadily trying to enter into negotiation. Implementation of timeline requires a drug company to pay rebates. If it's faster. Okay, co-insurance for catastrophic illnesses, so you won't get a lot of those surprise bills. And hopefully that they will have You can see amongst the thousands of medications that are available, they're only able to negotiate prices on a very small number. But it's for whatever it is, it's a small start. So beneficiaries will see some changes. And the insulin has already, we talked about it earlier. And so Part D, and some of the states, such as California, Colorado, Maryland, New York, and other states have enacted laws so that consumer protection and requires hospitals within their borders to increase their financial aid, and also that this will not go on your credit report. Okay, and some of the vaccines that used to cost a substantial amount, such as the shingles vaccine, is now available for free for those who qualify for it. Okay. So there are some tiny efforts that are being made. And just hot off the press, the president, Joe Biden, is proposing how to make sure that the Medicare stays solvent by increasing the amount of income that would have a Medicare tax rate on people who have substantially high income, and they'll go up, relatively small by 1.2% type of thing. So this will, this way the system won't go belly up by 2030. Okay, and it will continue to pay for itself for the next generation. Okay, and so some of the, we already, this is again a rehash of the numbers. Okay, and so 100 million that they currently have a debt. Okay, and a lot of people have debts. Some have debts but 10,000 or more. And some of the poorest counties have which, where the Medicaid was not expanded. And Texas is on the top of the list, followed by Georgia and other states. Okay, all the measures which were passed in the Democratic-leaning states and conservative states such as Arkansas and Idaho have passed the measures also. Okay, and so there are different states, they are law unto themselves. New Mexico law requires hospital to screen patients whether they qualify for free or discounted care. Okay, and some of the smaller hospitals and charity hospitals are most vigorous in pursuing debts. Okay. Right. Okay. The last but not the least, as the NIH funding got cut back further and further, the research has been more industry funded. In the 1960s, NIH used to pay for more than 50% of the research. After this, the Bayh-Dole Act, which was passed in the 80s, there is a hand in industries to work hand in glove, and a lot of the researchers are funding our companies, and so that, and some of the data that is being published is so-called paper mills, that they are not as reliable as they used to be, so to speak, and to publish or perish is taking its toll. And again, it becomes like who owns the data, that sometimes the data is published, for the sake of publishing, and the drug companies try to present the research data in the most favorable light and comparing with a relatively competitor's drug, so and so they can again fudge the data dramatically. And there is a big incentive to commercialize type thing. So okay, and again, so some of the other drugs, which have been concerns, have been not published widely, in some of the professional journals, okay. So then they also have an interest in making sure that the drug companies continue to put advertisement in their things. So to get your articles published, it takes some who is context with the reviewers, and the drug companies have a big say in how the data is presented. And John Nidis, is a very polymath type of scholar, and published how a lot of the research findings are false because they are hard to duplicate in real life. And especially it's becoming so many, any paper nowadays has more than 5 or 6 researchers. So some of the data is, it stretches the statistical imagination sometimes. Okay, and our friend Peter Nime pointed this out to me in the journal that both in the magazine that he and I both read regularly, and the doctor data. So this was an interesting and mind-boggling as to how some of the data is number of studies that have been retracted, has increased more and more since the late 90s. You can see how and this is retracted. So that does mean that there are certain that may not be detected. Okay, and okay, let's see what we have here. Okay, see, these are suspected fraud. Downright, the data is totally erroneous, and there is plagiarism. There is copied. Okay, and they are withdrawn. Sometimes there is conflict of interest. So there are varieties of reasons why the data is retracted. Okay, and about 80 out of 800 papers had fabricated data that appeared even in review journals. Okay, and there have been more retraction in 2022, perhaps due to rush to publish during COVID. And countries, which you can just see that some of the developing countries are on the forefronts of these type of data. So starting with China, Russia, Iran, Malaysia, Egypt, India, and yes, even in US, there have been, and some of the more difficult subjects where the data, there's extensive, massive amount of data, which most people do not have the wherewithal to analyze, is the big culprit, such as molecular biology or the so-called Western blot of method of data. So that becomes very difficult for people to interpret and can be easily fabricated. Okay. And again, in the medical errors, it's a big problem. Okay, with so many people, the actors involved in this thing, medical malpractice. Just simple error, not necessarily malpractice, either intentional or unintentional error. For instance, the third leading cause behind heart disease and cancer. This was before COVID, of course. Okay, and this is hard, almost impossible to believe, but there we have it. Medical malpractice causes more than 250,000 deaths per year. Which is, when you look at how many people are in the hospital, that's not so surprising after all. And the number of errors have increased, and perhaps because the complexity of the disease has increased and patients are getting sicker. So, and sometimes, the malpractice awards can be as high as $1 million. And one can understand the more risky specialties continue to be neurosurgery, OBGYN, anesthesia. Okay, and common errors that we see sometimes are retained foreign objects during surgery, or incorrect body parts have been removed. Again, but the checklists have made a difference. Okay, and during birth, every woman expects a perfect baby, and sometimes things happen during a matter of minutes with lack of oxygen, or it's just the outcome is not desirable. So the birth injuries can be a problem. A stroke that can occur unexpectedly during any major surgery, medication errors, anesthesia errors, misdiagnosis, and so last but not least, failure to diagnose. And again, the biggest thing happens is that a lot of time people are not, physicians or hospitals are not transparent. I'll give you my own example. That when I was in hospital for, non-specific evaluation, the hospitalist did not even touch me and managed to write down a complete history and physical examination, how we go, and when I complained, nothing really was done. And the first person I met when I walked into the hospital was somebody called the risk management consultant. Okay, so I think they just wanted to avoid me suing the hospital. I mean, that's the state of the art. And again, a lot of the labor, at least in teaching hospitals, provided by residents, who, even though there are new regulations, of working only 40 to 50 hours, they end up working for as many as 70 to 80 hours, like they used to do in the old days. Every third night they're on call. Okay, and their chances are, when you're obviously when you're sleep deprived, the chance of error increases dramatically. And sometimes some of the residents have even died on their way home. Okay, and let's see, I'm not sure what do we have here. Okay, but I will just click and see if I can open the link. Oh yes, it worked this time. Yeah, let me see the screen share. Stop this one and share screen. See if I can start the other one. Is there somewhere? Nope, I don't see it there. No, somehow it didn't work. So let me just share the original screen, but we had the slides and continue with my talk here. Okay, all right. So that was false start here. So let's go forward. Okay, so we talked about the errors type of thing, and And this was again the surgical errors. I don't know, like this was a good example that I borrowed from Marty McCurry's book type thing, that some of the hospitals in New York City in the early 80s, they were doing far less surgeries, but they had as many as 4 differences in their outcomes because their mortality and morbidity were a lot higher. And instead of chastising them, they simply pointed out the numbers and the data after data collection statewide, and hospitals and the physicians, the surgeons in this case, involved did make a solid effort. Either they changed their technique, they went and got better training, they got better equipment, and again, they were able to decrease their mortality. And some of the hospitals which were on the highest and the worst end, they came down to almost into the acceptable range very quickly. So given enough incentive, physicians and surgeons are willing to change. And some of the surgeons who actually were not as competent as they ought to have been, they retired. So the hospitals did make effort, and especially because everybody avoids bad publicity with the local television station. Classic example of this is the famous surgeon Michael DeBakey, who was an elderly vascular surgery specialist who was called to operate on the late Shah of Iran to Egypt. And at that time, he was not, it was a long time ago that he had done abdominal surgery, and why he was invited, that behooves anybody's intelligence. And he failed to observe the simplest precautions, such as leaving an abdominal drain, and that caused the patient, in this case the Shah, to develop intra-abdominal sepsis, requiring major surgery, and perhaps hastened his death. So again, it's overconfidence of even a well-known surgeon, and he himself was an example that we talked about. And when he got sick at age 98, first he turned down the operation for dissecting aneurysm, which is the big blood vessels in the heart. Later on, he's changed his mind, and they decided to proceed with surgery. And at a long hospitalization and surgery, and after spending a number of months in the hospital, at the cost of $1 million, he passed away. So it goes to show that physicians themselves sometimes can be a huge cause for problems and the bad outcome. And how to choose a doctor is always an enigma for anybody, all of us. Even as being in the field, it's harder to know as to who is good. Sometimes, there's a word through the grapevine that, I would not even send my dog to the patient. So there is a code of silence that is there in the medical establishment. So if you have an inside information, that is of great help. The doctors with the best personality and the best bedside manner or best dress is not necessarily the best surgeon, as to who's a better quarterback when it comes to not to be on the front line, And sometimes physicians have not kept up their skills with the new procedures, just non-invasive surgery. And some surgeries are very easy to figure out because you can look up the data on the internet, And sometimes, the greed and being outdated and aggressive surgeons can be, and the advertisement is a big factor. That the hospitals would advertise, we have this big, MRI machine or this. So sometimes, don't be enticed by those. And obviously, any procedure is a number game. A doctor who does more surgeries is likely to have a better outcome overall. And the physicians can be classified as to those who are a lot more aggressive, who love to do procedures, versus those who are diagnosticians, those who actually do listen and to make them. So sometimes, the nurses have the best judges as to how, and it's always doesn't hurt to get a second opinion if it is covered, But that sometimes you may not have time, and you may be stuck with taking a surgeon who's available. That your own surgeon may not be on duty. Again, so this is a cartoon to those who don't retire can cause a tremendous damage, and the slide is pretty self-explanatory. What is the history of healthcare reform in medicine? That Teddy Roosevelt proposed as far back in early 20th century, and followed by the late bills that were proposed in 1915, and initially they were supported by the AMA. First, private insurance was offered with the Baylor, when they offered insurance to teachers. That if they paid a nominal sum of $5 or $6, hospitalization was covered, and that was the initial Blue Cross Blue was nonprofit, but when the commercial people entered, they could not keep up, and they formed different companies, which ended up being WellPoint, which is the big giant insurance company. And okay, let me see if I can open this. Okay, all right, yeah, okay, yeah, it does open. Let me stop that screen share and try a different screen share. Okay. Okay, let's see. Yeah, I think you should be able to see this one now. This is the Kaiser timeline of history. Let's go through that quickly. In the early 1900s, Roosevelt and Progressive Party and or social insurance, American Association publishes a bill for compulsory health insurance. So the labor was in favor of it, and the women obviously suggested that. And again, Baylor Hospital recommended a plan first one. Now, sometime during the war, this was included that as a fringe benefit type of thing and was not taxed. So that's why the labor opposed the national plans, because they already had their insurance covered and that was not being taxed, the fringe benefit that they got from their employer. So they were reluctant to sign in with when the better proposals were made by FDR and later by Truman. Okay, and again, the AMA mounted a strong campaign, prohibiting this. So there are varieties of error. To their credit, we must say that all the presidents have made attempts to improve, including FDR and Truman, and last but not the least, Nixon. Truman sent a message to the Congress with varieties of bills, and they were proposed, but the AMA launched a national campaign at that time opposing it. Okay, and employee benefits can be included in collective bargaining, the ball has been kicked down, and then military was already covered and the veterans were covered. Medicare and Medicaid were started. That opened a floodgate, so to speak, that the large number of elderly people were being covered for insurance. And then varieties of proposals that were proposed during the Kennedy era and even the Nixon era that were proposed, were defeated by various lobbyists. Okay, and you can just look through this, that they were, and last but not the least, Bill Clinton and Hillary Clinton made the effort, which was defeated by, slick campaigning as well. Yeah. And the Obamacare, we've all lived through that. So, okay. And obviously it has succeeded in a small measure type thing. So, okay. All right. And so this is where we are. And the Obamacare model was based on Massachusetts, that was passed. Okay, let me close some of these so I don't get, okay, all right, we're in business. Okay, we're moving right along. We've recorded about an hour's worth. And so this is just the guidelines as to how strongly how many times, they tried to defeat the so-called Obamacare affordable health insurance plan. And that is still, finally, it has come as a law of the land. Okay, so it's a very checkered history with varieties of attempts and with some success but mostly failure in having a universal health coverage. And this was during the era JFK had proposed health for elderly care, LBJ. Reagan was a spokesman for AMA. Okay. And again, no socialized medicine. So he was the campaigner for AMA, was the case. And okay, and there was a lot of racial integration finally took place after civil rights were passed. Hospitals were not integrated, as Joel talked about earlier. Okay, and the hospitals were sometimes resistant when inspectors came around, and the Louisiana blood supply was labeled black and white. Okay, so the America's old, problems continue to plague even the healthcare system. How the U.S. healthcare system is at present, is to say this. Hopefully, we can try to make some sense out of it. Out of a population, a large number of people do have private insurance. Some have public insurance in the form of Medicare, Children's Health Insurance Program, Veterans Program. But still, you can just see that at least 10% of people are still uninsured, type of thing. So this is the number is, and those are the ones who seek medical care. and that increasing the cost for everybody involved. Okay, so this is just a rough guideline type thing. So the payroll tax, which is paid by the employers as well as through your paycheck, and similarly, the Affordable Care Act, federal government pays 90%, states pay 10%. Long-term care is still, nobody has been able to handle that. It can cost in the best 90,000 per year. It can keep going up and up. Assisted living is about 45,000. Okay. And then again, that there are brokers who line you up for Medicare and they are handsomely rewarded. They get as much as 4% for finder's fee for the life of the insured person. Okay. And again, the one option that would be beneficial, the Medicare for all, which would say 15% of the overhead cost, and no party has the willingness to do this thing. So, and when you look at that United Healthcare Group, their profit was $20 billion in 2022. Biggest competitor, Cigna, had a profit of 6.7 million. Okay, and United Healthcare, their overall revenue was 324 billion. Okay, so this surpassed CVS Health, which was again in the same neighborhood. So these companies are as bigger than Google, some of the industrial companies. Okay, of the big technological giants, I think so. And again, the biggest revenue is that maker was Optum Health, which employs as many as 60,000 doctors and treats 20 million patients. Okay, they're one of the biggest employers, of physicians nationwide. Okay, and so some of the numbers are, impressive to say the least. Okay, what is there and where does it cost so much? Look at some of the insurance pays. This is all the non-profit insurance hospitals. Okay, and Children's Hospital, in varieties of countries. Just an example, and their CEO salaries were anywhere at least 5 million. Okay, and on the other hand, the healthcare chief executives of various Tenant Health, Hospital Corporation of America, United Health, okay, their salaries were 20 to 14 million. So they may as well be playing football for all that for all that we can say. And so, so numbers were, impressive numbers to say the least, so, and they know that they have this something called a charge, they can charge whatever they want. And there's a game that is played, that they keep raising the premium. At the same time, the insurance companies keep asking for bigger the discount. Okay. And just to give you some local flair as to a lot of the cost of the bypass surgery in various hospitals, and they're all comparable. There are not too many outliers type of things. So, some of the costs they are even so. And the numbers are 30-day survival, discharge home, so it depends upon the overall score. This is given by the Society of Thoracic Surgery. Okay, and see, and these are the causes of death, which you can see the heart disease is still number one. Okay, these are the data that is number one, followed by cancer, preventable medical errors. That's what I wanted to emphasize. You can see that, it's right up there in the list, along with other things. So, and to err is human, but in that case, somebody pays with their life. So this is something that we can, there is a lot of scope for improvement type of thing. So again, it's unintentional injuries, the accidents right up there, okay, and again, the delivery of healthcare is very asymmetric, to put it mildly. The rates of hip replacement can vary anywhere from 1.5 to 4.8, depending upon which states or which areas of country you look at. So again, the healthcare is not universal delivery or availability of healthcare that we can point our finger at. Okay, and again, so we're talking about the United Healthcare, some of the big giants. It was Bill McGuire, was the founder, along with the other companies, and their business had increased from 400 million to 70 billion, and then he was convicted of stock fraud, option fraud. Okay, and they paid fines of up as much as 124 million. And the same way, Hospital Corporation of America, the Rick Scott, he failed to expand Medicare. At the same time, when he was part of the healthcare. He took fifth, but a number of times, and they paid one of the biggest fines, for milking Medicare. So one of the biggest settlement that was to get offered. Okay. So it's and you can, okay, this is an older chart, but again, you can just see how the prescription for success profit for the hospital corporation increase, from a relatively small amount, in the 70s to, in the range of 240, million, by 83. So it's an older chart, but it still shows the exponential growth of the hospital corporations. All right, and again, the lobbying, okay, these are some of the numbers that are again equally staggering. The lobbying, okay, this is increase, 70% increase from 2000. The big pharma lobbies up to in the range of 200 million, insurance companies, hospital, and obviously the AMA and other people are not too far behind. Okay, so that's, and again, we seem to be taking a lot of drugs, we Americans feel close to 4.5 billion prescriptions. This is nearly double that of 97. I mean, did actually the amount of disease actually did double? I doubt it very much, but that's that's the numbers that is being quoted, I think. So it's a huge number of changes that have taken place. Okay. Now, word or two about Medicare. Okay, and Medicare has morphed into varieties of forms. This is the so-called Medicare Advantage that has been offered now. Now, this is one can say that it's neither Medicare nor Advantage. So let's see if I can open this. No, this one does not want to open. Oh, yeah, it did open. Okay, the dark history of Medicare privatization. Okay, this is offered by organization which is ORG, it's a nonprofit. Okay, the dark history of Medicare expansion. So it talks about why it was invented. It's because it invented, type of thing. Because from the government people who did not like, the Medicare. So this was like given as a crappy insurance policy, and then it became a big money-making machine for companies. Okay, let me stop the share. These are some of the points that this article does, because in 1973 the HMO Act was passed, but there was universally disliked because the choices were limited. Medical Advantage became a big money machine by providing various restrictions and pre-approvals and a review, and again, gaming the system by enlisting varieties of conditions such as depression or obesity, and getting more and more payment. So a simple payment for an operation would be $9,000. By adding comorbidities, they're able to extract as much as $30,000 from Medicare. And the regulations are outnumbered and outgunned because the system is so complicated that the regulators can know it. There are few outliers are caught, but again, they're spending tons of money on, and again, the physicians are judged on the amount of how many tests that they order. Okay, and so this is becoming such a lucrative system. The private health insurance companies, okay, that even the hedge funds are getting into this business. They're picking up as a new investment strategy type thing. So it's becoming a big business on science, and the numbers there. Some of these companies are bigger than the tech giants, as we talked about. Okay, let's see what happened here. Okay, let me minimize this. Yes, yeah, okay, we're back in business here. Okay, and again, so Medicare. So what they are doing is, they are offering some excess fringe benefits, and then they're charging Medicare a lot more, and pocketing the difference. So Medicare ended up paying Medicare Advantage plan $140 million extra, if then they would have been, and the so-called risk adjustment score has become a big moneymaker for Medicare Advantage companies, starting with United Healthcare and the other big actors. There are only like half a dozen companies which are controlling them. This is an example of which are some of the most expensive states. The average hospital markup is 6.4% in Texas, Nevada, California, Mississippi, so these are, and we are not too far back. You can see how this is, some states are far more expensive for hospital stay and cost. So this was an interesting data. And sometimes even the state where Medicare charges for are totally different. Again, we talked about the trust business. I think I showed this earlier type of thing. So the survey of trust in healthcare system. Yes, I think I might have sent it out to you earlier. So this is a different survey. Okay, and depending upon race, ethnicity, and the various demographic. Let me see if I'm sharing this one correctly or not. Nope, I wasn't. So let me share this one. Yeah, you should be able to see this one now. Okay. And that physician trust decreased during COVID. Trust in clinicians is greater than the healthcare. People do trust the doctors, but they don't trust the system. Okay. And you can see how physicians, trust themselves or not, so this is okay. And so this is, we can see that the doctors are trusted and the public's and similar perceptions. So these are varieties of way the data is interpreted, okay, so a lot more interesting data that is being generated by it. This is a very extensive survey that was done. And so, but long-term care is again, frowned upon because people have doubts about what the quality of care in nursing homes. Okay, which is not a new data, but this again, Okay, so varieties of interesting information that is available for those who are care to know. Okay, let's see. Let me see if I can share the second screen. Okay, all right, and let's go away from this. Close this, close that. Okay, I think I have my notes again. Okay. And so the art of medicine, it's like we see that how, is amusing the patient while the nature cures. This is a statement from the Enlightenment era of Voltaire. But again, we have come a little bit further away than this thing. Art of medicine is love for humanity. Okay, these are some of the axioms that are well known from the classics. Okay, and all the risk, there is always risk to life from the day you're born. Basically, we all know that. It's always better. So earlier you can address a problem, the better would be. But again, it's like, talking to a patient has a lot more value. Okay. And again, on the other side, the wrong side, we have all about avoiding death. When again, art of listening is lost. So this is so varieties of other ideas are being tried. Now, this is something that my colleague Joel may frown upon, so-called integrative medicine, where the high risks of chronic diseases continue. Okay, they're not adequately prevented or treated because again, they're polygenic or multifactorial. And human beings will always be imperfect or work in progress. And again, sometimes, the treatment can be a lot worse than the disease itself. Okay, so these are again very obvious truths, but again, they're very valid. Chronic disease account for 75% of the nation's aggregate spending. Okay, utilization of alternative medicine is, becoming more and more popular. Okay, complementary alternative medicine in conjunction with modern medicine. So sometimes, we should not frown upon it. We should be prepared to accept your ideas. So, okay, and the physicians and some of the because of the demand from the public, this is again where the conventional medicine guidelines are changing. So even the very famous institutions are offering the so-called integrative care. There's been a surge of public interest, okay, type thing. So, and again, even places like Mayo Clinics, Johns Hopkins, Cleveland Clinics offering varieties of services for stress management and massage therapy, mind-body therapy, acupuncture, okay, even so-called yoga, Tai Chi, and supplemental consultations. So those are being available. How valid they are, or whether some of them have more placebo effects, that remains to be seen. Okay, but and some of the more medical myths, that I thought that those were interesting to point out. Okay, I know that 8 glasses a day, we only use 10% of our brains. Okay, and then hair. Okay, so this is shaving hair growth. So this is interesting myths that we have carried. They're widely spread in general public. I thought that would be of interest. Last but not the least, we could see that the primary care provider, his work is being taken over by varieties of consultants, okay, that everybody, from general practitioners, from internist has been, sometimes general and family practice, along with nurse practitioners, physicians assistants, and there is a whole cadre of developed called hospitalists, and has been 50% of new internists have become hospitalists, and that a lot of that is staffed by women and foreign international medical graduates, and so the varieties have become doctors instead of being bedside physicians, have become proceduralists, and so that is a big, trend. They have declined type thing. So, okay. And we talked about that sometimes the so-called acumen or gut feeling has become a thing of the past type of thing. So, okay. And in 1990, we saw the rise of what became known as evidence-based medicine. It should be conducted on the basis of best evidence, not based on relying on conventional method. And initiate patients with compassion and place patients at the center of diagnosis and treatment and patient-oriented treatment. Clinicians should learn to teach in the way that solves clinical problems. Okay. That solves the clinical problems based on, so this is, these are varieties of obvious truths, so to speak, and to employ a stricter approach about the just relying on the test numbers instead of treating numbers. And so these were the ideas that were introduced with, by a physician named Gordon Guyatt at McMaster University, a concept of scientific medicine, and along with clinical epidemiology. And there was something called Cochrane collaboration. They were at the forefronts of it. And to eliminate bias in clinical research based on randomized control trial, which is the gold standard based on which a lot of these things were. Okay, let's see what do we have here on this link. Okay, and there you go, how to understand and conduct evidence-based medicine. So let me stop the other share and start a different share screen if I can. Okay, yeah, hopefully you can see this. Okay, this was the abstract that was published on something called evidence-based medicine. Okay, have been not, and so they've experienced difficulty in understanding the technique, and it discusses the history of evidence-based medicine. Okay, it refers to conscientious, explicit, judicious use of current-based evidence based on which clinical decision should be based. Okay, so but it gets very academic at that time. Okay, but that's that's the way of the future, so to speak. Okay, let me go ahead with the original screen share. Okay, minimize this thing. Okay, close. Okay, so that was about the evidence-based medicine. Okay, and these are the varieties of levels, so-called evidence of level 1, which is randomized control trial, which is the gold standard. Okay, with a high chance of probability. So in probability theory, and okay, and it becomes, so sometimes the uncontrolled, so it's called the level 3 evidence. Okay, and they just basically an interesting case report. There's no evidence for that at all. And there are varieties of categories with how safe that is. It should not do any harm, and the care should be equal. So these are the varieties of categories that we should be judging our treatment of. Safety, patient-centered. It is delivered in timely, effective, efficient manner. I think so. And there are varieties of choosing it wisely criteria have been proposed type thing. So a lot of times, physicians always used to go about, in my experience, that means they've treated one case. In my series, that means they've treated two cases. Large number of patients in my career that I've treated. That means they've treated 3. Okay. So this is, so that's what, instead of that, we're going based on a real, on the gold standard of probability, or the p-value has become the gold standard. Okay, but again, this is very hard to interpret because there are as many as thousands of papers that are being published, and we are watching data and information that is available doubles every 72 days. So there is no way you can keep up with the thing. Okay, so again, it takes, the amount of information that is available at our fingertips has made it a little bit easier, but still, it's extremely hard for an average physician to keep up with this thing. So varieties of institutions, College of Physicians, Institute of Medicine, they're publishing data, judging the thing. So sometimes, and quality versus quantity becomes, sometimes some specialties are more guilty than others, as to but especially oncology, because they would say based on simple numbers rather than actual quality of lives. So they're, they would continue to say, okay, well, based as to how many extra days that patients would live, but the quality of life factor is being overlooked. So okay, let's see what we have here. Is it's the heart disease data that, again, we have the healthcare finder. You can find out the prices now. Some of the data is becoming more transparent that is available. For example, you can just go to the site and see what the cost of the varieties of procedure is at various hospitals. So this is, I plugged in the data for the local system. You can see how the cost varies. And the Brandon is more expensive than even Tampa General, okay, for some of the procedures that you can see. So, there is some transparency. Some of the cover is being, and then again, you can see what the state-wise data is, or what the data is in Hillsborough County. So but it takes an effort, and it takes a very skilled consumer to go to skim through this data that is available now. Okay, again, this is choosing wisely. So varieties of societies of cardiology, American College of Cardiology, they're publishing various recommendations as to how to come to the conclusion. Okay. Okay, we already talked about the Medicare Advantage and disadvantage type of thing, okay, earlier. Okay, so this is basically the same thing, as to how some of the insurance agents are increasingly rewarded for promoting Medicare Advantage. And you can see how much commission that they would make, per year type of thing. So you can see that the numbers are for promoting these things, so they're not small numbers, for recruiting bodies. I think so. Okay, I should move this slide further. So, and market share for various health insurance companies, the United Health is right up there, followed by Anthem and other companies. You can see how that, they're controlling a huge amount of market. And there are moves from some types to privatize even more part of Medicare type. So, yeah. And again, some of the games that they're being paid is to minimize expenditure of patient care. Okay. See patients, but first of all, trying to recruit people, limiting the networks, don't cover the hospital that need the most expensive care. So there are varieties of ways that they are able to typical coding versus upcoding gain that is being paid. So as I showed you the example of earlier, and from 9,000 to 30,000 as to how by adding certain coexisting mortalities. Okay, you can see how they've changed the number. Morbid obesity from just plain obesity, so the score is being upgraded, I think so. Okay, and again, we already talked about some of the drugs costs that that were passed, and some of the drugs which are dramatically expensive. The treatment for thalassemia, okay, is as much as 190,000 per year. Even simple treatment for skin dermatitis is 36,000. Some of the prostate drugs, end up costing as much as 2,000 per month, while the same drugs in a generic form in India is about $250. Okay, and we already talked about the satisfaction type of thing. Okay, and the overuse of technology, we had already given an example of thyroid cancer in Korea. Okay, and so. Yeah, so there are different varieties of use type of thing being done. So a lot of unnecessary care that is being delivered in over screening that is being offered all over the country, and that all adds up as in terms of cost as we go along. Okay. Last but not the least, the most important part towards the end of the things, varieties of medical philosophers have talked about medicalization of death. There was a guy named Ivan Illich, he was a Catholic Jewish science polymath who was in philosophy and history. And from Rome, he had moved to New York and then to Puerto Rico, and he'd become talked about the evils of modern medicine. That instead of eradicating pain and suffering, we have become death and medicine. Even the death has become medicalized. So he wrote some varieties of scholarly papers on iatrogenesis, illness caused by the medicine, including the clinical, social, and cultural loss of the ability to accept death as a part of life. So, so that was the big this thing that he emphasized and pointed out that things inappropriate medical treatment, the so-called loss of ritual, how people die has changed dramatically over the past years. Instead of being surrounded by the family with occasional medical support, we have become a limited medical support, family support, and it has become a medical event. And finally, the Lancet had reported the commission of death, and the varieties of scholarly articles have been published on that in the Lancet, over the last few years. Okay, and again, the denial of death has become a big thing, and we have created a lot of diseases that we talked about earlier, which did not exist before. Okay, and again, so we could try to flight from death, and a search for immortality has become the big holy grail, and trying to attain that. So writers of philosophers have introduced this issue, along with some of you may know, so-called good death. Elizabeth Kubler-Ross wrote, think about it, in the 60s. Okay, and the varieties of drugs that we're offering towards the end of life, they have little or no established benefit. Okay. And on the other side, we've talked about varieties of definitions of death. Criteria for death were defined by the Harvard Committee, included unreceptivity, unresponsiveness, no movement, no respiration, no reflexes, brain stuff, flat EEG repeated after 48 hours. That's how the death was defined, by a relatively small number of experts. Okay, and so. And then there are varieties of things, like, we have, on one hand, we've instituted a speed limit, but at the same time, we have, varieties of other things, are continued, such as boxing or football. Okay. And so, and now certain states are accepting physician-assisted death. A doctor is allowed by law to end person's life by painless means, as long as the person in the family agree. And so this is doctor-assisted suicide if the patient requests. And there are voluntary euthanasia that's carried out, which is legal in varieties of countries, such as, and the list is substantial: Australia, Belgium, Canada. And so varieties, and even varieties of US states are also, it's allowed: Oregon, Washington, D.C., Hawaii, Colorado. Okay. And we had already mentioned about the diving bell. And again, this was Atul Gawande, who was a surgeon and of Asian Indian ancestry, trained in born and raised in U.S., had wrote about his own family's situation about being mortal. Okay, and so this a variety of people have tried to address this issue about the final days of life, and this makes a very scholarly reading, where he shared his personal stories as his patient, and as well as his patient's experiences, at great length. Okay, and this is the data from Lancet. Let's see if this one plays. Okay, yeah, let's.
What happens after you die is changing. You could become a firework, or even have your ashes scattered in space. You could choose to come back to nature with a woodland burial. Maybe you know what you want after you die. But how about before then? Death and dying are much more complicated.
These are issues that are going to affect all of us, and at the moment, the way we're dealing with them is leading to increased suffering. People are are having treatments they don't wish to have, families are not involved, conversations are had too late, people are not getting pain relief, people are dying alone. These are real urgent issues that are happening now.
When we talk about caring for people who are dying, this is more about life rather than about that one moment of actual death. We'll say wise things like we'll cross the bridge when we come to it. But this is not an easy bridge to cross.
Dying in the 21st century is a story of paradox. Some of us are overtreated in hospitals as family and community are pushed to the margins. Others are left to face death all alone.
Most discussions are centered around high-income countries. The suffering in low and low middle-income countries is simply invisible. It's tough even for me. Her whole body is in pain. We now can do better.
In Kerala, India, state reforms alongside engagement with families and thousands of volunteers is pioneering a model of compassionate communities, changing how people live and die.
She says, sit down. She's saying she's much better. This is Lata Kumari, whom we saw last evening. Looks so amazingly and so happily different.
It was kind of everything I hoped I would find somewhere, and it was amazing actually finding it, because they really were creating this whole new model of care, changing the way people cared, the way people died, the way people thought about death and dying.
Across the world, groups are challenging norms and rules about caring for people at the end of life, and bold new models of compassionate community action are emerging.
What inspires me is knowing it can go right. It doesn't happen by accident. But when I see it happening in living rooms, in bedrooms, in care homes, in hospitals all around the world, it's really inspiring. Because although it doesn't take away the sadness and the loss that is so significant, it does take away the stress, the anxiety, the fear that so often just compounds these times.
Allowing the community to come in means training them, answering all their questions, and sometimes being questioned. It means giving up some of my power as a doctor, engage them as partners.
The Lancet Commission on the Value of Death convened experts in health and social care, philosophy, economics, and theology, working with community activists to set out the principles of a realistic utopia, a new vision of how death and dying should be.
What we're talking about in the Commission is whole systems change. It interfaces with healthcare systems, with the law, with policy, with education. All of those, death and dying, are social issues, and at the moment we're trying to solve them with a medical lens, and that's what needs to change.
We need to talk about what we want for ourselves when we die, and what choices we want for society.
If we want vaccination done across the country, we have a vaccination drive. Maybe we need to have conversation drives in every country. If we talk about this openly, confront the issue, we'll be able to avoid a lot of needless suffering, needless treatment. I have prepared my advance directive. I've indicated that in the context of an incurable illness, I should not be subjected to inappropriate life-prolonging treatment, partly because that will only be suffering for me, partly because I will be isolated and separate from my family, but also because out of loyalty to me, my family may destroy themselves with that needless treatment. That's a precious time when I should have been receiving a kiss on my cheek from my grandchild. It can be a time of healing also.
We can learn lessons about death from many different cultures, and from the innovators who are showing us new possibilities for the future of death and dying.
You only get one chance to do this. I heard a lot of people say, I wish I knew what they would have wanted. The conversation ahead of time is actually something you can give to those around you, and the gift that they can give back to you. Death it's not just a physiological event at an end point, it's so much more than that.
The realistic utopia starts with each of us facing this, bringing life back to death. It's about leaving a legacy, talking about those we miss, and finding a way through all the sadness to show up for those whose time is short.
Let me clarify that we were not really talking only about death. We were talking about life. What holds meaning in your life for you?
Okay, so that gives you room for thought. Okay, let's continue with where we left off right after that sobering conversation. Let me just minimize mine slides so I don't. Okay. Yeah, we letting go. So this was again the same thing for Lancet that we talked about earlier. So I think being mortal, and there are other physicians have talked about, a physician named Kieran Sweeney, was died from mesothelioma, and obviously the last lecture of Randy Pausch was dying of cancer that became very famous. It was an internet phenomenon type thing. So, and again, it's like they things, fear of litigation sometimes makes people continue this thing. So, and then again, customer concierge doctor phenomenon is playing some role, and sometimes the physicians try to sell themselves. For example, the physician who administered propofol to Michael Jackson, okay, and I think it was a cardiologist named Conrad Murray, I think so. And then recently there was a last book written about when breath becomes air, of a physician who was dying of lung cancer. Okay, and then Kieran Sweeney, who wrote in the British Medical Journal about the care he received during his illness, he did not follow the clinical care. The transactions have been timed identically. The staff fell short when it came to relational aspects and displaying, hesitation to be brave. He described his own fears, anxieties, and confusion that he felt, how the actions of the staff only worsened some of these. So a lot of people have given some thoughts during the last days of their own mortality. And again, the varieties of famous people who have talked about their cancer, death and dying, including Christopher Hitchens, who was diagnosed of esophageal cancer, but unrealistic expectations. Susan Sontag wrote about, illness as a metaphor. Stephen Jay Gould, Stephen Jay Gould, who said that, somebody has to be an outlier of the treatment when he was dying of cancer. Okay, and he did survive longer than average expectancy of his advanced cancer. Emmanuel Ezekiel, his book we discussed during Rich Kennedy's Social, as to how he would not want any treatment after he's 75. Okay, so the varieties of people have addressed this in public forum. That thing. So, and Stephen Jay Gould's book was "The Median is Not the Message," about he's an outlier, type thing. So, and again, sometimes we have unrealistic expectation when we do cardiopulmonary resuscitation. We think that, okay, well, and a lot of times, we have broken ribs type of thing, with continued CPR, So that's, those of us who've gone through the training have actually, are very familiar with this phenomenon. Okay, and again, this is the fear of privatizing Medicare. Here's an interesting video by a very focused group, that this is maybe, let's see if I can play this. No, I think not. Sorry, fear of. No, I'll have to find this, and send it out separately because somehow, the link is, has broken type thing. So. Some of these videos that I have, that Okay, yeah, this is the previous frontline
But she
video.
had the baby.
Being mortal, that was, it's just
You
long
want to be
video.
part of that 15% that survives one of
It's
the
a
fighters. You want to be that part of that group so bad.
of frontline.
Spend a little bit of time as a family.
So that was one of Atul Gawande's video, okay, about being mortal, okay, which is an interesting video, but it's rather long, so I will skip that at this time, okay. And let me go to the second screen and minimize this. And okay, and I think we have just only a couple of slides. This is what about critical care, America versus world. That is also a frontline video. Okay, it's interesting. Last but not the least, we have to always end on the fun view, which is, which is from Yes Minister as to how the administrators are taking over basically, and
thinking about going solar, but not sure whether it's worth it.
so it's that's enough thing from Yes Minister and all those things. So I think we're coming to the end of our talk, and I will see if I can share my screen again. Okay, and share screen, and let's see if what else I think I have. I don't think I have any more slides probably. Okay. Yeah, share screen. I think we're finished with this, and I'll stop my recording, and I will see you folks probably next time, and we'll open the floor up for discussions, and I'm sure a lot of people have a lot of comments about some of the stuff that we heard about, and we'll continue recording for a little while, and I'll say, and we'll send out the addendum as after it's finalized. Okay, thank you, folks.